about are drugs that you guys will be using a lot of and will come into contact with a lot when you're junior doctors and be expected to prescribe when you're junior doctors, and actually are quite dangerous drugs if not used properly. So it's worthwhile as I go through the lecture sort of concentrating on the therapeutic aspects of what I say. Okay, so we'll start. So as you all know, disorders of hemostasis or clotting are very common. And there are major reasons why patients come into casualty or come into A&E. There could be arterial events such as a stroke or myocardial infarction. It could be a venous event such as a venous thrombosis in one of the deep veins of the leg, or a pulmonary embolus. You all know that. Going back to last year, I don't know how much you remember from my lecture, but what you should remember is Virchow's triad. It's this, essentially there are three factors which might lead to somebody having a blood clot. Okay? It could be due to a problem with blood itself, the components of the blood, so the blood may be hypercoagulable. That may be an inherited problem, such as protein C deficiency, protein S deficiency, antithrombin deficiency, factor V Leiden mutation, prothrombin mutation. They're all inherited thrombophilias. They can all make the blood hypercoagulable. Or it could be an acquired problem, such as antiphospholipid syndrome. Okay, antiphospholipid syndrome is very important actually, because it's the exception to this slide. It might even be worthwhile you writing that on the side. Antiphospholipid syndrome is important because not only can it cause venous clots, it can also cause arterial clots, and particularly it can cause arterial clots in young patients. So if you get a young man or a young woman with an arterial clot, you should always think antiphospholipid syndrome. Other acquired reasons why your blood can be hypercoagulable are things you will all know: smokers, estrogen, so that could be pregnancy, or could be young women on the pill. Okay, the second constituent of Virchow's triad is the vessel wall, and that's particularly important for arterial clots. And so patients with atheroma in their blood vessels are, as you all know, at risk of cardiac events, and of course at risk of cerebrovascular events. And then the third constituent is actually the blood flow. So there's the blood components, the vessel wall, and the blood flow. If blood flows less quickly, i.e. if there's turbulence, that again can lead to blood clotting. And again, that's relevant, particularly if you've got some sort of disturbance within the heart. If there's a dilation of one of the heart chambers, such as a dilated cardiomyopathy, you can get clot within the heart. If you've got inefficiency within the heart, such as if the heart is fibrillating, again you can get arterial clots. Okay. In terms of the venous system, in situations where you're immobile and your calf muscles aren't contracting and you're not helping your valves push blood back to your heart, again, when there's stasis of blood, that can lead to clots, and that's one of the major reasons why patients get DVT. And that's one of the reasons why really almost all medical inpatients and almost all surgical patients will all be on heparin, for that very reason, that they're immobile post-surgery and so they're at risk of a venous clot. Okay, so that's Virchow's triad. Now we're going to go through the different sort of agents that we can use to anticoagulate patients. We're going to go through warfarin, heparin, then talk a little bit about the direct oral anticoagulants that some of you may have heard of. I do need to talk a little bit about. And then at the very end, we'll talk a little bit about aspirin and some of the antiplatelet agents. Okay, so warfarin has been around for something like around 80 years now, 1930s. So it's the sort of was always thought to be the gold standard anticoagulant until very recently. And the way it works is it inhibits the production of vitamin K dependent clotting factors, such as factor 2, which is prothrombin, factor 7, factor 9, and factor 10. Things you must know about warfarin: it has a very long half-life. That's important because it takes ages for it to get out of your system. So if you have an operation and you stop your warfarin a day before, you're still going to have a lot of warfarin in your system. That's important to remember. Okay, so the operation will therefore be unsafe. It has a slow onset and offset of action. That's what I've talked about, the offset of action, but also the onset of action. When you start warfarin on a patient, that patient is not immediately anticoagulated to a therapeutic level. They need to be bridged with heparin because it takes about 3 days or 4 days for the warfarin to be at a therapeutic level. So it's a slow onset and a slow offset of action. And importantly, it's reversible. So if a patient comes in with bleeding, being on warfarin, there's something you can do about it. There's an agent you can give to reverse the effect. That's called prothrombin complex concentrate. That's important and relevant, and we'll come back to why in a bit. So how does it work? Well, I've just already mentioned it inhibits the synthesis of vitamin K, it works on the liver, and therefore anything else affecting the liver can potentially affect the way warfarin works. Okay. Pharmacokinetics, it's given orally, and so by that you can imagine it's absorbed well from the gastrointestinal tract. It's always been thought to be the preferred choice for long-term anticoagulation, but that's now challenged. There are other drugs available which are challenging that, but for the majority of the last 80 years it has been the preferred choice because it's oral, okay, and because it's reversible. We talked about the slow onset of action and the need for heparin cover when you start anticoagulation, and I've also talked about this need to stop the drug approximately 5 days before any surgical procedure. It's heavily protein bound, which is also worth remembering, and that's why it's so it has such an association with drug interaction. There's a long list of drugs that can interact with warfarin. For example, antibiotics. If you've got a patient with an infection who's on antibiotics and they're on warfarin, and you're a doctor seeing these patients, you might often find that their INR is up or their INR is low, and that's because of the antibiotics. So in clinical practice it can be a real problem. It's a bit of a pain, really, warfarin. Now the clinical consequences, because as I showed you that picture of the liver, anything that affects the liver can affect warfarin, particularly alcohol. Okay, if you've got a patient who likes to drink, that's a problem if they're on warfarin, especially if they binge drink. If they're drinking the same amount every day, it's not particularly good for them, but it's not going to affect their INR so much because it's going to be constant. Okay, but if they're binge drinking, their INR can go from a therapeutic level to quickly having an INR greater than 8. Okay, and that patient is a high risk of a bleed, even an intracerebral bleed. So alcohol and warfarin just don't go. There's also a long list of drugs that can affect the P450 system. I've not mentioned them in the lecture. You just need to be aware that when you've got a patient on warfarin and there are other drugs, you check the BNF, you ring your pharmacy department, and you check whether there's any potential interactions, particularly if you're starting a new drug. Okay. Pregnancy. Warfarin is potentially teratogenic. Okay, that means it can cause serious abnormalities in the developing fetus. So if you've got a young patient, a patient with the potential to become pregnant, you need to make sure you've counselled them so that they know that if they're trying to conceive, okay, that if it's a planned pregnancy, if they're trying to have children, that they may well want to consider coming off warfarin in advance, okay, and switching on to heparin or some other anticoagulant to try and take that risk completely out. Okay, there are certain patients who are at such high risk of clotting that we even consider giving them warfarin in pregnancy. Okay, and they're patients with metallic heart valves. We will always stop it in the first trimester, but in the second and third trimester, once they're over that period where the fetus is developing, we will then even consider restarting it. So the risk is greatest in the first trimester. The risk in the second trimester is not that great. But in the third trimester, you're obviously a bit nervous because if the patient goes into labour and they've had warfarin the day before, they're going to bleed everywhere. Okay? So, in the third trimester, we're also a bit nervous, and we try and stop it more often than not, by 36 weeks when we do give it. There's advantages about warfarin as well, which I should mention. It can be monitored. You know where you're at. So if there's a patient on warfarin, they come in with a bleed, there's a blood test that you can do that allows you to establish exactly how thin their blood is, and that's the prothrombin time. Okay? The prothrombin time is a blood test which is done in a light blue tube, a citrated tube. Okay? The full blood count is done in a purple tube, which is an EDTA tube. EDTA and citrate are the name of different anticoagulants, which basically line the blood tube and stop the blood clotting when you take the blood. Okay? So you guys just remember, light blue is for clotting. All right? So that's a test you do to monitor the warfarin level, and it's expressed as a standardized ratio, which allows you basically to have the same results wherever you went. So if you're a patient on warfarin and you get admitted, in Milton Keynes, or if you get admitted to Stoke Mandeville, if you get admitted in Northampton, if you have a prothrombin time done, the prothrombin time might be different for the different lab that you have it done in, but the INR will be the same. Okay, so that's essentially explaining what an INR is. It's an express ratio of the prothrombin time. We already talked about the drug interactions, and I'm not going to go through them all. There's just too many for you guys to remember. I think the take-home message is warfarin is there's a high risk of drug interactions. Some drugs will potentiate the effect of warfarin. Some drugs will inhibit the effect of warfarin. You just need to check with the pharmacy, and you need to check with your BNF. I'll go over this quite quickly. Yeah, I'm just going to mention the anti-epileptics and rifampicin. So rifampicin, does anyone know what rifampicin is? Yeah, when is it most commonly used? Yeah, that's right. So if you've got a TB patient, they're going to be on that drug for almost 6 months. Okay, so it's something just to be aware of. Okay, and valproate is the only anti-epileptic which doesn't affect warfarin. The others are, I'm sure you've heard of carbamazepine, phenytoin. All these anti-epileptics can do. Because you've got an epileptic patient in whom the anti-epileptic medication's been changed and they're on warfarin, alarm bells ring in your mind. Okay. So the main indications for why a patient will be on warfarin, and I've already talked about the common clinical manifestations in clinical practice. So they might have a venous clot, such as a DVT. If they have a below-knee DVT, then you have to have at least 3 months of warfarin. Okay. If you have an above-knee DVT, it's a minimum of 6 months of warfarin. Okay, just remember that. Pulmonary embolus, 6 months minimum. The evidence actually doesn't show any difference in giving 6 months or 12 months. Okay, there's no, in terms of by difference, there's no increase or decreased risk of bleeding, and there's no increase or decreased risk actually of recurrent clots in giving 12 or 6 months. The reason why we give 6 months is because we perceive that if we carry on with warfarin for longer, the risk of bleeding outweighs the benefit in terms of a recurrent clot. Okay? Just so you know how risky warfarin is, per year there's a 1 to 2% risk of major bleeding with warfarin. Okay? If you take that into a lifelong cumulative risk, there's about a 20% risk of being on lifelong warfarin that you will get a major bleed. And that includes an intracerebral bleed. So, you know, that's why we're reluctant to carry on for more than 6 months. Sometimes we have to. Okay. Atrial fibrillation, lifelong. Okay, because of the risk of stroke. And in atrial fibrillation now, warfarin is no longer the gold standard treatment. Okay, there is another drug or other group of drugs that we now prefer, and we'll come on to those later on. Dilated cardiomyopathy, because of the dilated ventricle and the stasis of blood as it goes through the heart, there's a high risk of arterial clots which can then flick off. Okay, so that's why those patients are also on lifelong warfarin. Patients with mechanical prosthetic valves have a real issue. One, they've got a foreign body in, so that again increases the risk of clotting. Secondly, it's a valve, so it's turbulence of blood as it goes through. So those patients are at particularly high risk of clots, and we keep their INRs higher. Okay, between the range of 3 to 4. So essentially, their blood is doubly thin as somebody on warfarin who's had a DVT or a PE. Okay. Now this is particularly relevant if these patients need surgical procedures, and they might need surgical procedures like anyone else. Okay, and your worry really is, normally with a surgical procedure, you stop the warfarin 5 days before to make the surgical procedure safe. Okay, and often we don't bridge patients, and by bridging we mean give heparin. Okay, we just leave them off their warfarin and let them have their surgical procedure. In mechanical valves, we don't do that, and that's because of the great worry we have of them clotting their valves. Okay, and so those patients almost always are bridged, and often they might be bridged with IV heparin, which is a real faff and will be the bane of your life as a junior doctor. Patients on IV heparin. Okay, and we'll come to that. And at the bottom there I've written antiphospholipid syndrome. I mentioned it earlier. Antiphospholipid syndrome is an acquired thrombophilia. Okay. Characterized by antibodies in the blood, which might be antibodies against beta-2 glycoprotein I or antibodies against anticardiolipin. Okay, it's relevant to all of you because if you get a young patient who comes in with an unexpected clot, so that might be a upper limb clot, it might be a young patient with a stroke, it might be a young patient with no risk factors for for an arterial event who then comes in with an arterial event, you think antiphospholipid syndrome. And if they do have antibodies, or if they do have lupus anticoagulant and it's persistent for 12 weeks, those patients need to be warfarinized long term with a high INR because they're at very high risk of clots. So warfarin's very common. Okay, there's lots and lots of people out there on it. I'm sure you've all seen a yellow book before. Okay, and it's estimated about 1% of the population are taking warfarin, and traditionally it's always been viewed as the gold standard. But there are several limitations, okay? I've already talked about the unpredictable response, and that's because of the fact it's heavily protein bound. Lots and lots of potential drug interactions. There's also numerous food interactions, okay? Any food that goes, things like grapefruit, for example, things which induce or inhibit the cytochrome P450 system can potentially cause interactions with warfarin. Alcohol we've talked about. Also the slow onset of action, so it takes some time to have an effect, okay? And the slow offset of action, which is an issue if someone has a complication such as a bleed. And because of the risk of bleeding, and because the therapeutic window is so narrow, okay, the window is between 2 and 3. I'll show you a slide in a minute which shows that if your INR is less than 2, the warfarin is doing you little good, okay? And if your INR is greater than 3, the risk of bleeding goes like that. So it's really important you monitoring it. And for patients, it's a real hassle to be on warfarin for 6 months or even lifelong, and then to have your blood monitored every 2 to 4 weeks and try and hold a job down. It's not that easy, actually. I know, because my dad's on warfarin and he hates it. And this is a slide here showing wrong way. What's the pointer? Don't know. Oh, no, not that one. Anyway, I'll use my arm. So this is the slide I'm talking about. It shows here the INR is subtherapeutic, and you see this is in patients with AF, okay, at risk of stroke. All right, and you can see their stroke risk is high when the INR is close to 1 and reduces as you get close to therapeutic range. The stroke risk here of an arterial event is low because their INR is therapeutic or higher than therapeutic, but this is a risk of bleeding. You can see how it goes up as the INR is high. Okay, so that shows the importance with warfarin of keeping patients in the therapeutic range, and that's why patients need monitoring. Okay. So adverse effects, well, obviously there's a risk of bleeding and bruising if your INR is too high. We've talked about teratogenicity, and then we've also talked about the potential to reverse it. So if you get a patient who comes in with a bleed and they're on warfarin, what do you do? Well, the first thing you do is stop the warfarin, pretty obviously. Okay. You then need to consider whether they're bleeding or not. You need to do a blood test to check their INR, and it's also important where they're bleeding. Okay, because that's going to determine how serious the complication is going to be. You also need to know if they've got a valve, because if they've got a valve for the reasons I've outlined, stopping their warfarin could be a potential problem, even if they're bleeding. Okay, you'll still stop it, but you might need to do something to ameliorate the risk of clotting their valve off. And you wouldn't give them vitamin K. Okay, so if they've got a mechanical valve and they bleed, even though they're bleeding, never give them Vit K. Okay. The reason why is because vitamin K hangs around. It's not just an immediate effect, it hangs around for several days. And really what you want in these patients with valves who bleed is you want to reverse the bleeding as quickly as possible, and then ideally restart the anticoagulation as quickly as possible. Alright? But at a therapeutic range. Alright? So you don't want Vit K around. But if they haven't got a valve in and they bleed, and their INR is, let's say for example, their INR is above 8, okay, you would give them vitamin K. Alright? If their INR is above 5 and they're bleeding, you give them vitamin K, all right? And you would also, if they're bleeding, think about a reversal agent, okay? The reversal agent of choice is prothrombin complex concentrate. It used to be, when I was a medical student, it used to be FFP, or fresh frozen plasma. But now the gold standard agent is PCC, okay? And other names for Octaplex or Beriplex, you might hear junior doctors use those names, okay? But essentially it's prothrombin complex concentrate. It's the best reversal agent because it contains all the factors, 2, 7, 9 and 10. Okay? Obviously if there's a clear source of bleeding, they may also need to have an emergency procedure such as an upper GI endoscopy or a colonoscopy if it's a GI bleed. I sort of talked about this, but I mean, you know, these are the different ways you manage high INRs in patients without a valve, okay? And to be honest, you don't need to learn this or need to know this. These are things that you'll be provided with. There'll be a protocol. Whichever hospital you end up working with, there'll be a protocol. And there's no point remembering stuff like this because you just forget it, all right? But just an example of the sort of protocol that any hospital might have, all right? So moving on from warfarin, moving on to heparin, okay? So heparin's a glycosaminoglycan. It's got a glucose backbone. I'm not bothered if you know that or not, really, but I'm meant to tell you about it, so there you go. It's produced by mast cells. It binds to antithrombin 3. So that is important. Okay, the most important in clotting is thrombin. Okay, thrombin's got this direct role in potentiating the development of a fibrin clot. Okay, and so heparin's important because heparin works well because it basically acts right in on thrombin via antithrombin. Okay, so it binds to antithrombin via this unique pentasaccharide sequence, and that's relevant. We'll come to why that's relevant in a bit. It activates antithrombin and then inactivates factor 10A, prothrombin, and activated factor 9. Okay, now heparin can be unfractionated or it can be fractionated. Okay, unfractionated heparin is IV heparin. For your understanding, this is the heparin that you need to give via continuous intravenous infusion and needs continuous monitoring. Okay. Fractionated heparin is also known as low molecular weight heparin, and this is the type of heparin that you're going to come across most in your clinical practice. Okay. It's basically heparin that's been cut up into a lower molecular weight, but to include that pentasaccharide sequence. Okay. So it still works, but it's different from unfractionated heparin. And we're going to talk about the different pharmacodynamics and pharmacokinetics. Okay. So unfractionated heparin is obviously a longer length because it hasn't been fractionated. It's given by continuous intravenous infusion, almost always. The exception is in patients with renal failure, okay, who need a prophylactic antibiotic, so not a therapeutic, anticoagulant, not a therapeutic anticoagulant. And in those patients, we can't use low molecular weight heparin, because low molecular weight heparin is almost exclusively excreted by the kidney. So patients with renal failure, we have to use unfractionated heparin prophylactically, but that's the exception. Apart from that, it's almost always given by continuous IV infusion. Okay, it inhibits prothrombin and factor 10. That's important, and we'll come to why. Okay, and therefore, because it inhibits both prothrombin and factor 10, its effect can be monitored via a blood test called the APTT. So in the same way that warfarin can be monitored via INR, so remember these terms, warfarin, INR, okay, heparin can be monitored via APTT. Okay, again, that's a blood test in a light blue tube and a citrate tube. Okay. Low molecular heparin is much smaller because it's been fractionated. It's given subcutaneously, not intravenously. Given subcutaneously, it has a very high bioavailability, greater than 90%, and it's cleared by the kidneys, as I've already mentioned. Okay. Its great advantage over unfractionated heparin is its predictability. Okay. Because it's predictable in terms of its high bioavailability, over 90% is getting in, all right, you can give it at a fixed daily dose, just once a day. You don't need to give it by IV infusion. It's a subcutaneous, under-the-skin injection once a day. So it's far better and easier for patients that are being on a drip and a continuous IV infusion. And that's why IV heparin use in the hospital is now very minimal. Okay, not many patients on it. The vast majority will be on this, low molecular weight heparin. However, it's a different agent, and because it's smaller, it's not large enough to inhibit prothrombin. Okay, it only inhibits factor 10A. Okay, and that's why it can't be monitored by an APTT. So if you've got a patient in on low molecular weight heparin and you do their APTT, it's not going to help you. It's not going to tell you how much drug is in their system and how thin their blood is or isn't. Okay. In fact, if you need to monitor their level, which you really don't need to do because the pharmacokinetics are so predictable, okay, but if you do need to monitor their level, you have to send a special blood test called an anti-10A level. And that isn't available in all hospitals. That's usually only done in tertiary centres. So, for example, here in Milton Keynes, we send it off to Oxford, okay, when we need to know what the level is. The only situations where we actually do that are in pregnant ladies, okay. The reason for that is in pregnant women, the weight changes. Their weight from when they're starting heparin to when they eventually deliver, obviously their weight goes up, and the dose is weight dependent. So because we need to know exactly what their dose is, depending by their weight, we check their anti-10A levels. Apart from that, we very rarely do anti-10A levels. Okay. Oops. So this is really just a schematic sort of picture which shows the difference of unfractionated heparin and low molecular heparin. I don't know where the pointer is, so I'm going to point. So this is unfractionated, that's low molecular heparin. You can see that's much smaller than that because that's longer. It can bind to both activated thrombin and to antithrombin 3. Okay, whereas low molecular heparin can only bind to antithrombin 3 and not to thrombin. Because of that, you can only monitor this one, unfractionated heparin, with an APTT, because the APTT is basically dependent on it's measuring your thrombin. Okay, it's measuring your prothrombin time. Yeah, it's in your activated thrombin. That's what it's measuring. The 10A level is needed for this one here, the low molecular weight heparin. Right. And this is just a summary of what I've talked about. Okay, the difference in the two agents. Unfractionated heparin is not predictable. That's why you have to give us a continuous IV infusion, and you have to monitor the APTT probably every 2 to 3 hours in patients on unfractionated heparin. Whereas low molecular heparin is predictable, no test required. You can give it a fixed daily dose. It's given subcut. Okay. Right, so the uses of heparin. I've already mentioned lots of this, but it's largely used in the hospital to cover patients who are at risk of thrombosis around times of operation, okay, when they're immobile, when there's stasis of blood, and it's also useful in patients on warfarin who are going to have a procedure. You need to stop the warfarin 5 days before because of what I've talked about, the slow offset of action, okay? But some of these patients are high risk of clotting, such as patients with valves, and so in these patients you need something to bridge them. You can't leave them off an anticoagulant for 5 days, so you use heparin. Okay? Out of the two, you always would rather use low molecular heparin for the reasons I've outlined. Okay? And it's the major anticoagulant that you'll see in the hospital on patients who are inpatients. So medical inpatients, the way it is these days, there has to be a reason not to give it. Okay? So if there's a bleeding risk in the patient, for example, they've got a low platelet count or they've got some other reason why they might be at greater risk of bleeding than someone else, then you wouldn't use low molecular heparin prophylaxis. Apart from those patients, all inpatients should be on low molecular heparin prophylaxis because the risk of DVT and PE in patients in hospital who are unwell and just lying in their beds. Okay? And there's a big government drive around that. If there's an inpatient who has a DVT or a PE as an inpatient, we have to fill in all sorts of forms, and it's a big problem. So, you know, there's a big push to make sure all your patients are on these drugs. Use of heparin in treatment, well, DVT and PE. So any patient you want to use warfarin on, because warfarin takes about 3 to 4 to 5 days to be in a therapeutic effect, you need to use heparin first to bridge them. So not only is it used prophylactically, it's also used therapeutically. Okay, in both venous and in arterial clot. So that's in acute coronary syndrome, myocardial infarction, we'll come to, DVTs and PEs, and also in atrial fibrillation. Okay, and in pregnancy, it's the anticoagulant of choice because no other anticoagulant is safe in pregnancy. Okay, warfarin we've talked about is teratogenic. Okay, and the novel oral anticoagulants that we're going to talk about, okay, they're not trialed in pregnancy. They're not yet safe in pregnancy. So the only thing you can use safely is heparin. Okay? And obviously you're not going to want to have a pregnant woman in hospital for 9 months, so unfractionated heparin's out. So the only drug you can really use is low molecular heparin. Adverse effects of heparin, well, bruising and bleeding is obvious. There's also risk when you're using it in the long term of osteoporosis, okay? Particularly with unfractionated heparin rather than low molecular heparin. And there's also a risk of this thing called HIT, or heparin-induced thrombocytopenia. This is quite a rare thing, and it's getting rarer because we're using less unfractionated heparin. Okay, it's an autoimmune phenomenon. It happens about around 10 days after patients have started heparin, and basically their platelet counts plummet. So they come into hospital with a normal platelet count, and within about 10 days their platelet count is usually around 10. Okay, anywhere between 10 and 20. Now you'd think that these patients might bleed, but they don't. Okay, the big worry with these patients is they clot. They get clots despite their low platelet count, and because of that, they need to be anticoagulated despite their low platelet count. And what you'll find is when you anticoagulate these patients, they end up reversing their low platelet count. Their platelet count normalizes, and then you start them on. And more often than not, you then start them on warfarin. Okay. The treatment is to use one of these different anticoagulants that I haven't mentioned so far. It's called fondaparinux or leporudin. Leporudin is going out of fashion. The one we tend to use now is fondaparinux, which is basically a synthetic heparin. Okay, so it's a pentasaccharide synthetic heparin, which is used for this thing called HIT. There is a blood test that you can do to confirm the diagnosis, and that's a laboratory assay, but that takes about 4 or 5 days to come back. So often you just treat patients based on the clinical presentation. So you've got a patient on heparin whose platelet count drops within 10 days and they develop a clot, it's almost certain they've got HIT. Okay. So if you've got a patient on heparin who's bleeding, similar to warfarin, you stop the drug. There is a reversal agent in the same way that there's a reversal agent for warfarin with PCC, with heparin, with unfractionated heparin you can give protamine. Okay? And you can monitor the effect of the protamine by using the APTT blood test. For low molecular heparin it's more complicated. Okay? It can't be fully reversed with protamine, which is the downside of using it. And so in some patients where you're very worried about anticoagulating them, because you know they're also at risk of bleeding, you actually choose unfractionated heparin above low molecular heparin for that reason. Because you know you can't reverse low molecular heparin, whereas you can reverse unfractionated. Antiplatelet drugs. We're right for time, yeah, just about. Yeah. So I've talked about warfarin, I've talked about heparin. Now we're moving on to antiplatelet drugs. And these are relevant, these drugs, for patients with arterial clots. Okay? So going back to Virchow's triad, these are patients with abnormalities of the vessel wall. And if you remember your lecture from last year, which I'm sure you won't, when patients have an initial cut, what happens is the first driver to hemostasis is that platelets bind to the interruption in the vessel wall, okay, by something called von Willebrand's factor. Okay, that's what happens. All right, it's a primary platelet plug. So in these arterial clots, the main thing going on here is damage to the vessel wall, platelets sticking to it. Okay, and then that is then the surface for the clot thereafter. So that's why it's important with arterial clots that rather than just trying to thin the blood, which is of course more important for venous clots, you actually need to act at where the problem lies, i.e. the platelet is the central problem in the clot. Okay, and that's why antiplatelet drugs are the mainstay of treatment for patients with arterial events in terms of secondary prevention. Your patients who've had a stroke or patients who've had a cardiac event, almost all of them will be on some sort of antiplatelet agent. Okay? Most common, of course, is aspirin, which acts by inhibiting COX and affects platelet activation. There's other antiplatelet drugs like dipyridamole, which is phosphodiesterase inhibitor. There's clopidogrel, which is getting more and more common. It tends to be used now more and more by neurologists in patients who've had strokes. They like clopidogrel. You might well find your patients on clopidogrel rather than aspirin. It's also quite commonly used by cardiologists after patients have stents put in. Okay, cardiologists get very tetchy about clopidogrel, and if you try and stop it as a houseman, they'll come down on you on like a ton of bricks. I don't know why, but they do. So they love clopidogrel, and their patients with stents will be on clopidogrel for at least a year afterwards. Okay, they'll often have dual antiplatelet drugs, aspirin and clopidogrel. And finally, there's these glycoprotein 2B3A inhibitors, which inhibit platelet cross-linking and activation, and they're used in patients with unstable angina. And yeah, here we go. So glycoprotein 2B3A inhibitors, like tirofiban's one example of it, and they're used in high-risk acute coronary syndrome, and also after coronary intervention, percutaneous coronary intervention, so angioplasty. Thrombolysis. So thrombolytic agents target the final bit of the coagulation cascade. Okay, if you remember from last year, okay, you develop a fibrin clot. Prothrombin, thrombin, fibrinogen to fibrin clot. What happens is the fibrin clot does not get broken down by heparin or warfarin. Okay, heparin and warfarin just prevent that clot from propagating. The fibrin clot itself gets broken down by the body's inherent fibrinolytic system. Okay. And the fibrinolytic system is the conversion of plasminogen to plasmin, and plasmin breaks down the fibrin clot. Okay? So if you've got a patient with a major life-threatening clot, such as they've got a SD elevation MI, or if they've got a Sanderl embolus PE, these are patients with hemodynamic compromise, these are patients who are at high risk of dying from that event. You can't really hang around by using heparin and warfarin and trying to stop that clot from propagating. It's already big enough to kill the patient, so preventing propagation isn't enough. So that's why in those patients you think about thrombolysis. And that, for want of a better word, is a clot buster. Okay? You're basically stimulating the fibrinolytic system to break that clot down. Okay? And when you're doing that, you're weighing up the benefits and risks of what you're doing. The benefits are you're trying to save the patient's life by preventing them dying of their MI and having an arrest, okay, or a saddle embus having arrest, versus the risk of them bleeding and having an intracerebral bleed. So that's why you don't use it for everyone. If you don't think there's a risk of sudden death, then you'd rather not use it, actually, because there's also a high risk of bleeding with these drugs. All right? So that's this, weighing scales that you're weighing up in your mind when you're seeing these patients, in A&E. But as I've said, it's used for patients with ST elevation MI, massive PE. It's increasingly being used in stroke, but of course that would be directed by the neurologist, I'm sure, to weigh up that balance of bleeding versus benefits in terms of the stroke itself. And it works by promoting fibrinolysis by converting inactive plasminogen to active plasmin. And the plasmin degrades the clot. Two types that you need to know about. I hope this slide is still relevant. I don't use these drugs, but there's recombinant tissue plasminogen activator or TPA and streptokinase. That's certainly what was around when I was a houseman. Wasn't that long ago. Right. These are the drugs I want to concentrate a little bit of time on, and that's because by the time you guys become doctors, okay, these will be all the rage. They already are, to be honest. In fact, any patient that comes to see me or anyone who asks me for advice who has an index clot, I will need a reason not to use these drugs because I think these drugs are great. All right. So these drugs are tablets. Okay. So they're oral, right? They directly work on thrombin or on factor Xa. Okay. And they're predictable. So they've got the best of both. They've got the best bits of warfarin without the worst bits of warfarin. They've also got the best bits of heparin without the worst bits of heparin. Okay. Names, the direct thrombin, and the giveaway is in the name. So if it's got an X in the name, it's a 10A inhibitor. Okay, so apixaban, rivaroxaban, X, that means a 10A inhibitor. The other one's the bigatran, which is a direct thrombin inhibitor. Okay. The advantages of these NOACs, they were called NOACs, they're now called DOACs, so they're not new anymore. So novel oral anticoagulants or direct oral anticoagulants. Advantages are they've got a rapid onset and offset of action. So as soon as you start the drug, the patient's anticoagulated. Within 4 hours of starting it, they're anticoagulated. Right? They've also got a rapid offset of action. So if you've got a surgical procedure using this drug, easy peasy. Just stop it a day before. You're fine next day. All right? Very few drug interactions. Very predictable pharmacokinetics, so you can give it either once or twice a day and no monitoring is necessary. So no need for these patients to have a yellow book or go to anticoagulation clinic. They've got quite a wide therapeutic window which you can give them just once or twice a day. And in terms of cost to the health service, potentially, if you look at the whole health service in its entirety, it can save a lot of money because it will eliminate the need for regular coagulation monitoring and allow fixed dosing in adults. Okay. Its uses, it's now the drug of choice in atrial fibrillation, okay, and the drug I would use in atrial fibrillation is a drug called apixaban, okay, which has been shown to have the most reduced risk of bleeding, the same efficacy in terms of preventing stroke. They can be used in the treatment of DVT and PE, okay. You don't need to bridge with heparin straight away, okay, so you can just use one drug from the very outset. It can be used in prevention of recurrence. We always used to say 6 months anticoagulation and then stop. The reason we said that was, as I said earlier, because we were worried about the risk of bleeding with using warfarin over the long term. This lifelong risk of 20%. These drugs, when used for longer periods, have a very similar risk of bleeding to aspirin. Okay, they have a risk of bleeding around something around 2%, okay, or 6% over a prolonged period of time. So they're far safer with regards to the risk of bleeding. So that's why we're now beginning to challenge whether 6 months anticoagulation is right, particularly in patients who've had a spontaneous clot. If patients have a triggered clot, okay, we're less worried because their clot happened because they were immobile or because they had surgery, and we're less worried about them having a recurrence. If they have a spontaneous clot without any risk factors, we're very worried about them getting another one because we don't know why the first one happened. So what's to stop them getting a second one? In those patients, we now are far more inclined to want to continue with anticoagulation lifelong now that we've got these drugs, because we're not so worried about the risk of bleeding as we used to be in the past. Okay. And they're also now being used in preventing DVT and PE post-hip and knee surgery. So rather than putting these patients on heparin, we're now beginning to use dabigatran, and that's actually what we do in the hospital. Okay, that's our protocol in the hospital. And that's it. And I'm on time. Great. Okay, so any questions? Oh, excellent.
Silence. Well, thanks very much for the lecture.
All right.
Dr. Dunkerweiler has to go back to a clinic at the hospital, so this is your chance to ask him questions. If anyone's got anything.
Oh, one at the back. Yeah, go on.
Can you briefly explain the difference between warfarin and heparin?
Briefly do the whole lecture again. Yeah. I suppose I can. You know what? Yeah, hang on, let's ask you a few questions. I'm doing all the work. Yeah, sorry, go on.
You mentioned warfarin has a slow onset, right?
Yeah.
So you use like heparin to gap the difference.
Yeah.
But like, why wouldn't you continue using heparin and you gotta use warfarin now?
I'll let you answer the question. How's warfarin given?
Orally?
Right. How's heparin given?
Well, there's IV and sub-Q, right?
Right. Yeah. So who IV is for? Which type of heparin is given IV?
Unfractionated.
Right. And how's that given? Is it given as a one-off shot, or is it given as a continuous? Right. And how's the low molecular heparin given? Subcut. Right. Daily. If you're a patient, okay, and you're you have a DVT or a PE, what would you prefer to do? Would you prefer to take a tablet for 6 months, or would you prefer to have a continuous IV infusion for 6 months, or an injection every day for 6 months? What would you? That's why. All right. Any other questions? Don't worry, I won't be so aggressive next time around. Yeah, go on.
With the novel ones, are they not going to just supersede it?
Yeah, well, there's cost implications, you see. So you know, I think they probably will. There's now antidotes being... So there was a lot of reluctance to start using them. When anything's new, there's always reluctance, and that's good, because, you know, warfarin's been around for 80 years. We know everything there is about warfarin. Okay, these drugs are newer. When something's new, you always have to be a little bit, you know, take a step back sometimes, because they haven't been around for so long, you don't know about the long-term complications of the drug. However, they've been around for at least 5 years now, and we're getting more and more confident with them. And there's now antidotes being developed as well. So dabigatran has an antidote, which is now available in clinical practice. Apixaban will have an antidote next year. Okay, so you're then less worried about even needing to reverse it, because you've got a reversal agent. So I think you're right. I think we will probably see at some point in the next 5 to 10 years, I'd imagine, that warfarin is going to go pretty much out. Okay, the exception being mechanical valves, because in mechanical valves there's no trials being done in patients with valves. Okay, because no one's got the guts to do a trial in patients with valves because of their worry about it. All right, and if there's no trial or evidence, these drugs aren't going to go through all the regulatory, you know, bodies. For example, NICE. Okay, so NICE is only just approved. By only just, I mean last year, about 18 months ago, approved these novel drugs for the treatment of venous thrombosis. The way they first came in was for AF. They've been around for AF for about 3 years now. Okay, but for venous thrombosis, they've only just come in, and that's because they were waiting for the phase 3 clinical trial data. Okay, but the trial data is really, really strong.
And presumably pregnancy would be another one.
Yeah, so pregnancy, again, no one will do a trial for obvious reasons, and so we can't use the drugs. So yeah, heparin's not going to go out of fashion in pregnancy. No. But fondaparinux is something else. I don't know if I mentioned it. I did actually. I mentioned it for HIT. So that's a synthetic pentasaccharide, okay? I know it's a bit of a mouthful, but if you remember, I talked about heparin. I talked about that pentasaccharide is 5 chains, all right? So that's the actual active bit of the heparin that works on antithrombin, okay? Whereas unfractionated heparin is this huge, long sort of structure. Now, fondaparinux is just direct, it's even cleaner than low molecular weight heparin. It just works just on the pentasaccharide. And we're now beginning to see that actually that is now the drug of choice in unstable angina, all right? It's an unstable angina or acute coronary syndrome. In those patients who need low molecular heparin, fondaparinux is actually safer. It's got a reduced risk of bleeding, okay, and it's just as effective. So, you know, all these standard things that we've been using for all these years are now being challenged, okay, and you'll find that in your practice that you become a doctor, you learn all these things in school, but things change, and you have to keep up to date, But these NOACs are definitely going to be. You're going to see a lot of those by the time you guys qualify. One more at the back. Yeah.
In terms of the heparin use,
Yeah.
I remember that you mentioned anticoagulants.
Speak up. I can't hear you very well.
So you mentioned in terms of the thrombocytopenia,
Yeah.
heparin use.
Yeah.
So you mentioned that you still give anticoagulants,
Yeah.
and the patient will likely to normalize. Explain how that's.
Yeah. I did mention it, but these patients have these very low platelet counts. Okay, but they don't bleed. Okay, they clot, and they often get really bad clots. They can get above knee DVTs and get P's, and so you need to anticoagulate them. But you can't anticoagulate them with heparin because that's the reason they're in the problem in the first place. It's an immune. It happens because heparin combines with PF. It's complicated. I'm not going to go through the etiology of why because you won't remember and you don't need to know at this stage. Okay, but essentially it's an immune-based condition which makes you prothrombotic. Okay, so you have to anticoagulate, but you can't anticoagulate with heparin. You have to use something else. Okay. And fondaparinux, while it is strictly speaking heparin, because it's only 5 chains long, it doesn't have the same immune effect as the long heparin does. Okay, and that's why it's safe to use. Okay, and it's the drug of choice actually in HIT now. Yep.
Okay, if I can understand why fractionated heparin can be used in patients with weight.
It can. Low molecular weight heparin can't. So low molecular weight heparin is renally excreted.
I mean, why fractionated?
Why can it be used?
Fractionated can't be used in patients.
It can.
Fractionated.
Unfractionated can. It can. It can. It's just where you're confused is what I talked about in the lectures. It's almost always used intravenously. Okay. But the exception is when it's used, because it's normally used for therapeutic reasons. Unfractionated heparin is usually used when you want a therapeutic anticoagulant. Okay, so do you understand the difference between therapeutic and prophylactic? Therapeutic means a higher dose to actually treat a clot. Okay, prophylactic means a lower dose to prevent a clot. Okay, so when you're using an anticoagulant for prevention, you would always use low molecular weight, not unfractionated, because it's easier. It's just an under the skin injection. Okay, the exception is renal failure. Because in renal failure, low molecular isn't safe if the EGFR is less than 30. Okay? And so you have to use unfractionated because unfractionated is safe in renal failure. That's the difference. Okay? Do you understand? Done? Great. Okay. Thank you very much. Pleasure.